So, thank you, everyone. I want to start my talk by thanking especially the scientific committee and also the local organizing committee, which is doing great. And I want to tell you a story, which is going to be brief, I promise. It is related to what does a mathematician do in this kind of meeting. No? So, I was a theoretical mathematician, an expert in differential geometry, and I had a tenure position at my university until my daughter Violeta was born. And then craziness started, and everybody in my surroundings thought I was going mad or crazy or something like that. But I finally found like a super pediatric endocrinologist from my city, from Córdoba. And also I found the Spanish Association for Fibrous Displasia, which is also like family right now, especially Nerea, which was the one who guided me. And when all this craziness was almost over and I came back to become only a mom, not a mom plus a doctor of my daughter. So I said, okay, so I think things with mathematics can be done in this field of research. But I was a theoretical mathematician, which was really, really far from applied mathematics. And then I contacted some friends, which were expert on applied maths. And they told me, we call ourselves applied mathematicians, but we are theoretical mathematicians indeed. So, and you have to go to, well, so they told me, if you want to do things which really have an impact on patients, you have to go there, to the mathematical oncology laboratory. So, which is at our university in Spain, which is really small. It is called the University of Castilla-La Mancha. It is not very famous. But there is a researcher which is called Victor García Fernández, Victor García Pérez, sorry. And he has created a lab. And at the beginning, I said to my friend, but it is an oncology lab. Fibrous dysplasia has nothing to do with oncology. And he told me, this lab was born as an oncology lab, but it now has the objective, or his main goal is put maths at the service of biomedical conditions. So I said to myself, okay, that's my place. So 3 years ago, well, a little bit less than 3 years ago, I started collaborating with these people from the Mathematical Oncology Laboratory. And in there, I found Maria, which already talked today, she was also just arrived in there, and she was also a theoretical mathematician, very far from what I used to be. She's an analyst and I am a geometer. But we focus on fibrous dysplasia, and we didn't want to publish mathematical papers. We wanted to publish things that had an impact on patients. So again, I talked to Nerea and I said, because my friend told me you need data. You need data and you need experts on the field, because you are in a really good place for doing things, but those people from lab work with clinicians, because without them we do nothing. We only do maths. We do applied maths, which are not really applied maths. So Nerea put me in contact with Diana, and Diana put me in contact with Luis. And thanks to Luis is that I'm here today. So right now we are Maria, well, I came back to my university at Córdoba, so I had to continue teaching my teaching duties, but I still do research on fibrous dysplasia. But we both are still focused on this topic, and we have the help of more people from that lab, which they are not only focused on fibrous dysplasia, but they help us with different kind of things, more theoretical or more immediate things. And three of them are mathematicians, one of them is an engineer, which is expert on images, and the other one is a physicist. So we have like a very multidisciplinary team. And as I said before, all this wouldn't have been possible without the help of Luis Fernandez de Castro, with whom I have talked like long hours, and also without the help of Alison, because she provided data. Without data, we would have done nothing. Okay, so after this story, what I wanted to do today is like a brief overview of what we are working. We haven't done much right now because we are few people. We are expanding, but things are slow. but I will be happy to share what we do with you. So the first topic I will be sharing is what Maria talked about today, but I'll be summarizing. It is a work on images. It is almost finished. Well, indeed, it should be finished by the end of the year. I hope so. And so our way of working is detecting a problem that we think we can tackle with mathematics. And so learning about the problem like a lot, reading, talking a lot with biologists or clinicians, so that we are sure that we have understood properly the problem, and translating that thing into mathematics. Doing our thing with mathematics and then translating it into a clinical language. So, well, when we talked to Luis, he as Maria said, he told us that they had data from a clinical trial with denosumab, in which 8 patients with more than 100 lesions underwent a treatment with denosumab, a 6-month treatment. Okay, as they told us, we have like longitudinal data, and we also have images from that clinical trial. Okay, the good thing about that images that we receive is that normally when we receive images at MOLAB or OLAB, they are not segmented, but these images were segmented. Were segmented from people at the NIH, from the team of Babak Saburi, and they were really nice because the segmentations were performed manually, which is not normal, and also were performed on the CT images, taking into account the morphology, so that regions which were not metabolically active were also considered. What did we do with those images? So what we wanted to do is, first thing is, we had baseline images and post-treatment images, and we wanted to know what was the thing that had changed the most after treatment. Okay, so for that, what did it was taking the CT and the PET scan, and using like 100 of mathematical measures, which are called radiomic measures, and applied them to those scans. So 100 measures for each lesion, and for each CT, and for each PET, pre and post-treatment. So what we found was like there were no significant morphological changes, which was something which was quite shocking for us. And what changed the most was something that was expected. That's a famous picture of Maria before. But because what changed the most was the submean of each lesion. In here, there is a graph in which we represent the amount of lesions with that submean, and since we have a discrete quantity of lesions, in order to do the graph, it is like they trace a curve. But it will be, so if we put the dots, it will be better. Today I have learned that it will be better for you if we put the dots of all the lesions instead of the curve, and instead of the word density. So in here we have that pre-treatment sub was distributed in this way, while post-treatment sub it has a peak before 500. So that was something that we expected, but what it shocked to us the most, it is like not all lesions behave the same. It is like each line is for one lesion, and the green lines correspond to lesions which has a pre-treatment submean level higher than a post-treatment submean level, which was the natural thing to expect. But what was new for us, it was like some lesions, those who have a red line, instead of getting a smaller submean value after treatment, got a higher submean value than before treatment. And so we wanted to know if there was something that could decide if a lesion was going to behave as a green one or as a red one with the baseline data. So we analyze also, again, we run all the measures, again, the 100 measures, we analyze them, but only for baseline images, and what we got is that the submean itself could be used as a predictor of what was going to happen. And so in here we can find each dot corresponds to a lesion, and each color to a patient, and in here you have the baseline submean, and here's the difference in submean. So those spots which are under this horizontal line are those who correspond with the red lines. So those who start with a not very high submean level, and after treatment, they increase their submean level. Okay, so after this analysis, what we propose is that submean for each lesion could be used as a predictor of the response to the denosumab treatment. Also, it was really interesting for us that the behavior in patients was not uniform. We can find patients which have like very different behavior, lesions with very different behavior, as Maria explained before, like the blue ones, for instance. Okay, so once again, we are not clinicians, we are mathematicians. So we work with data, and that's only what we obtain from the data we got from the NIH. And they are only 8 patients, but it's true that we treated lesions independently, so we have more than 100 lesions, but we will welcome a lot if you have any kind of images you want to share with us so that we can test, that we can validate these results. Okay, so what else are we doing? Well, this was the first thing we did, and it is already published. It's the only published thing we have on Fibrous Displasia, because as I said before, it all started less than 3 years ago. But what we mathematicians do in order to understand things is transform things into equations. And that's something we love a lot. And because it helps us understand things. And the idea of the equation, these kind of equations, for people who work in mathematics, they are not very difficult to deal with. So sometimes they tell us, you applied people, and your mathematics are not really difficult. But the really difficult thing is not the mathematics indeed, but the really difficult thing was to talk long hours with Luis and understand, reading boring modeling papers, we mathematicians, and from those conversations and reading a lot of paper, understanding from all the things that were in there, which were the driving factors that we thought could be driving the mechanisms of the disease. And so we put this into equation, and what for? Well, we are happy with that. But when we put things into equation, we can add things to the equations. So we can add things. In here, in this equation, there are many things which are hidden. Like, for instance, the rates of proliferation of the mutated osteoprogenitors and the rate of proliferation of osteoprogenitors, which are data which are unknown, or the rate at which stem cells differentiate into osteoprogenitors, and we can use this equation in order to ask the model things. So we can ask, okay, is the flow of mutant stem cells important for our model? And the answer for us was that, yeah, it was important. What is this graphic? Well, when we take the model, we can obtain an equilibrium point of the model. What does it mean? The equilibrium point is, it tells us the composition of the lesions in terms of the different population we have considered. This percent of healthy osteoprogenitors, this percent of mutated osteoprogenitors. And what we can do is see if we change the rates of differentiation of stem cells, do the composition of the lesion varies? And the answer is yes. So, and it is consistent with literature on age-varying composition of F lesions. So what we can see here is like, this is the parameter measuring the rate at which the stem cells are differentiating. And for each value of the parameter, we have the amount of each of the populations. It's like a percentage of the populations. And what we can see is that with that differentiation, varies, the composition of the lesion varies. So the more differentiation of mutated stem cells, the strongest, no, it's not the strongest, the more severe the disease. Yeah, which is in accordance with what we have read. But there are also some things which are like shocking for us. Yeah, as I said before, this is only a model, but we ask questions to the model and then we translate them to clinicians. This was shocking because the proliferation rate of mutant osteoprogenitors had nothing to do with the composition of the lesions. So the rate, and that was what our model was telling to us. That was something that we translated to Liz. So indeed, we asked more questions to this model, but I don't want to be, I want to skip to another thing. So this kind of work helped us understand the disease and also cancer to clinicians which are doing base research on FD to check hypotheses without using animals or person or in a cheap way. Okay, so it is not that it's going to substitute that, of course, but if you can, how do you say, if you have a broad range of things to check and you can narrow that broad change, it can make things easily. The last thing I want to share with you, it is a work in progress and is personalizing the denosumab treatment. It is also based on the same clinical trial. And the thing is that with that clinical trial, we got images from the NIH, but we also got longitudinal data on P1P and also on CTX, which is a biomarker of resorption. And so for each patient, we had like this kind of graph in which we have different measures of CTX that were performed on the patient, and also we have on the exact dates they were taken. We also have in here in blue, that is at which the patient received the exact days at which this patient, this one is patient 2, received the denosumab and also the zoledronic acid that was given to the patient after treatment. And so what do we want to do with this? I have to run. So what we need to do is also, what we did was also designing a model, but in this kind was a model that was focused also on resorption. And we work with these two hypotheses, no? That RANG-L inhibition by denosumab results in osteomorph accumulation, and that reconstitution of RANG-L signaling can activate massive resorption. So working with these two hypotheses, we developed like a really, really simple model of the interaction of osteoclasts and osteoclast progenitors, osteomorphs. And what can we do with that model? What we can do with that model is adding treatment to that model. Okay, so we have the model, we run the model, and at the prescribed days, we add the denosumab, that modifying the equation, and we also add at the prescribed date the zoledronic acid. With that, there are many parameters in here that we don't know, but for those parameters is for what we use the data we receive. So with that data, we are able to personalize those parameters to each patient. And what is the goal? The goal is this. The goal is what I want to do is to obtain a curve explaining the behavior of CTX, not at discrete points, but in the whole period of treatment. Okay, so, and it was really curious because for some patients which had experienced no rebound, our model predicted a rebound in this case, and it's no rebound. So what for all this, or how are we going to continue? Our idea is to personalize treatment for those patients. is like varying the dosage of denosumab and also the period between doses and see how does the curves evolve. That was all. Thank you very much. And as I said before, we will be really grateful if any of you could want to share data with us or collaborate with us, or we are completely open.
Thank you very much.